So the question is it emphysema or chronic bronchitis? If it's chronic bronchitis is an obstructive respiratory disorder when the inflammation of the bronchi, productive cough, and excessive mucus production occur. Chronic bronchitis versus acute bronchitis. It's different in that chronic bronchitis is not caused by infection, and symptoms will develop and persist longer. Again, chronic bronchitis versus acute. Even I say acute is mostly viral, but in chronic bronchitis, this is nothing really related to bacterial or viral infection. It's an inflammatory response to cigarette smoking or other offending agents like chemical exposure, and the inflammation will result in mucous glands will start developing hyperplasia, edema, mucus production will increase, bronchoconstriction, cough in defense against inhaled irritants. Of course, many of you heard that smokers cough, and it's like almost musical cough. I mean, there are no whizzes, but it's like this. You can tell just this is coming from cigarette smoking, and it's so sad that it's really, truly 100% preventable, and you still see people smoking on the streets. The health fad of 80s and 90s seems to be gone, and cigarette smoking getting back in vogue, I would say. So again, education of your patients is important. When all of this occurs, pulmonary defenses really die, especially our cilia. All the cilial waves are dying, and cilia dies, and phagocytosis decreases, and on the top of chronic bronchitis, respiratory infections will occur and start developing, and bacterial infections will be very, very common. Emphysema is an obstructive respiratory disorder that will result in the destruction of the alveoli or the alveolar walls, and it will lead to this huge permanently inflated alveoli. So lung tissue will remodel when it grows and will repair if inflammation occurs. Enzymes are involved in this process. They will be influencing or preventing the excessive tissue damage. So with the smoking, the enzyme deficiency may occur, and sometimes again people have familiar predisposition which will have the enzyme deficiency, which will cause enzyme deficiency. However, the smoking again, which initiates inflammation, will cause changes in enzyme levels and structural damages, structural changes. Emphysema will gradually affect the alveoli. They will start growing or developing into large, irregular pockets, and the pockets have huge holes in this. So all this leads that patient will start losing oxygen getting into the bloodstream. Elastin and surfactants keep the alveoli open and are slowly destroyed. So there is no elastin anymore, so alveoli will collapse during the expiration, and air will be trapped in the lungs. So the recoil, the main thing, the recoil is lost, in the hyperinflation of the alveoli will be narrowing the terminal bronchioles, and this all will lead to a distinct shape of the chest of the patient with COPD. So patients with COPD will often hyperventilate, and they will have this pink appearance to their skin, and the shallow breathing pattern, or hyperventilating breathing pattern with pink skin will lead to pink appearance, and will lead to puffing sound. So this is like a bad name to use, but to help you remember, the patient with emphysema will be called a pink puffer. And this is a picture that says that patients with emphysema and chronic bronchitis are using accessory muscles to help with the breathing and to make breathing more effective. So patient will develop barrel chest, and that's also significant finding, or physical examination finding, observational finding of the barrel chest. In here you can see that's emphysema because of the all the efforts to increase the oxygenation. Barrel chest will develop. This is another picture that shows VQ scan, which will be here really revealing VQ mismatch. You see ventilation, how big it is, it's huge, and perfusion is normal. Yeah, so that's what causes mismatch. So if there's a VQ mismatch, it's a sign of like COPD. And this is typical patient with end stages of COPD, where patient already losing the reserves of fat, to everything is leading towards the development, towards the maintenance of oxygenation, maintenance of this high respiratory breathing rate, and patient will have this with typical appearance. At the same time, because of the compensatory mechanism, patients with COPD may develop the increased hemoglobin and hematocrit to compensate. Again, fast respiratory rate, and let's talk about the symptomatic treatment. Symptomatic treatment, bronchodilators, the usual albuterol, and I don't want to spend much time on this because that's the review of undergrad course. Mucolytics, most common, or Mucinex, cough suppressants, inhalers, and definitely avoidance of the exposure to the upper respiratory infection or any type of infection that can lead to exacerbation of COPD. Cough suppressants, again, is a good idea, quality of life. And mucolytics, you have to sometime to do a explanation and education of the patient, because patients think they don't have cough, but they have chronic bronchitis. They don't have cold, and they know they have COPD. So mucolytics, thanks to TV advertisements and Mucinex, consider this cold weather medicine, but people with COPD may need it year-round. Pneumonia is inflammation of bronchioles and alveoli, and it's caused by infection by bacteria, virus, or anything else. Any other pathogen can be to blame. So pneumonia may, as I said, have viral or bacterial character, and those two in diagnostics may have some notable differences. So pneumonia in viral case may lead to non-productive cough, but in bacterial case the cough will be productive. Viral pneumonia may result in low-grade fever when bacterial is a higher, and viral pneumonia patients may have normal count of white blood cells. Bacterial will present with the left shift. And on X-ray, bacterial pneumonia, which classic pneumonia, will be presenting with infiltrates, and while we're looking at viral X-ray, there will be no or very minimal change. Of course, in viral case, you don't give antibiotics, but bacterial will be responding to antibiotics very well. And again, if the organism even isn't determined, certainly it's a good idea to go ahead and do some kind of sputum culture to determine what the causative organism is. So what happens in pneumonia pathophysiology wise, it may be a different origin based on the offending agent. For instance, if we have an aspiration pneumonia, the gastric content or tube feeding formula can reach lung tissue, and it will irritate and trigger inflammatory response. So inflammatory response from the aspirate will increase mucus production, and mucus production will lead to atelectasis and pneumonia development. And especially tube feeding has nice mixture of sugar, of protein, so it's a nice medium to grow bacteria. It's like Petri dish. So, and if pneumonia develops, the activities of daily living will become very difficult, and patient will not be able to move or even talk normally, and coughing will be very disabling for this patient. So if patient coughs and there is mucus production, again hydration becomes important. When we hydrate the patient, the secretion become very thin and easier to expel. So type of pneumonia you can call lobular pneumonia when one or more than one lobes involved. Bronchopneumonia is actually the most frequent type. It's a patchy pneumonia throughout several lobes. Interstitial pneumonia, it's very atypical, and it will occur in the areas between the alveoli, and interstitial pneumonia may caused by virus, and it's a sequela in influenza, or interstitial pneumonia, and I'll finish right here talking about it, may be caused by uncommon bacteria such as Legionella, and Legionella is the famous disease that when it occurred first time was described at the American Legion conference, and then after that it was described very well, and the treatment is very well available. So nosocomial pneumonia is, of course, you know that it's a hospital-related pneumonia, and the contrasting type is community-acquired pneumonia. So unfortunately, the situation is so bad with pneumonia in hospital setting, we even have special name for it, nosocomial versus community-acquired pneumonia. So again, treatment may vary depending what was causing the pneumonia.